Hello and welcome. My name is Angelica Ford Davis, and I'm a volunteer with ThyCa. And if you're here for this session, it's the discussion about the updated anaplastic thyroid cancer guidelines with Dr. Kebebew. Dr. Kebebew is an endocrine surgeon at Stanford Hospital and Clinics in Stanford, California. He's an internationally recognized expert in endocrine oncology and surgery. He's performed more than 3,000 operations on the adrenal, parathyroid, and thyroid glands, and for neuroendocrine tumors of the gastrointestinal tract and pancreas. Dr. Kebebew has published over 400 articles, chapters, and textbooks, and serves on the editorial board and as a reviewer for 54 biomedical journals. He has received awards from the American Cancer Society, American Association for Cancer Research, American Thyroid Association, American Association for Endocrine Surgeons, and International Association of Endocrine Surgeons. And he's a very nice person too. All right, and Dr. Kebebew, I'll let you take it away.
Thank you so much for that really kind introduction. It's an honor and a delight for me to be participating in the 24th annual Thyroid Cancer Survivors Conference. It's been some time. The last one I participated in was in Philadelphia, but the virtual world now allows us to all engage frequently. And I'm really presenting the new American Thyroid Association Anaplastic Thyroid Cancer Guideline on behalf of many talented providers who worked very hard on this guideline, which really required updating. And right off the bat, I have a picture of an archaic picture of a surgeon performing an operation. And I have that up there primarily to share with you much has happened in the management of anaplastic thyroid cancer, where the outcome of patients is much improved. I do not know for this venue if I need to state my disclosure, but I have nothing to disclose in regards to this presentation or really any other medical presentation. I don't know if that's a good thing or a bad thing. At any rate, what am I going to talk about? I'm going to share with you some guiding principles and definitions and classifications for anaplastic thyroid cancer. And perhaps the most exciting part of this presentation to me and you is what treatment options that you have. And then I'll briefly go over some specific guideline recommendation and good practice statements that are new. And I think you as patients and this association should be familiar with. So who worked on this guideline? Believe it or not, we started this back in 2017. I have there pictured my colleagues, myself and Keith Bible had the honor to co-chair this distinguished group. And this was at the annual ATA meeting, and I believe this was in Canada at that time. Iteratively, we've worked on refining the guideline with emerging new data. And finally, after 4.5 years of working on it, we felt that it was good enough to get it submitted and published. And hopefully this will be helpful to many providers that will end up seeing patients with anaplastic thyroid cancer. So what was the composition of the guidelines committee membership? As I already shared with you, I'm an endocrine surgeon. Primarily, I think because I've done research on anaplastic thyroid cancer and published on it. I had the honor to co-chair it with Keith Bible, who's a medical oncologist at the Mayo Clinic, who recently retired. We had 19 expert members, and they were selected and accepted by the American Thyroid Board of Directors. Stipulation was that it would be new members. So 11 of the new committee members were new and represented 13 different institutions, really an international guideline, including colleagues in Europe and Canada. There, I have the composition of the specific specialties involved, but what I'd really like to stress, and especially for this audience, is that we had patient advocates as part of the guideline and making it really practical, and their input was so fantastic for us to develop a refined guideline that was user-friendly, not just to providers, but patients themselves. And I'll share with you at the end of my presentation, I think a resource that would be very helpful for your membership as well. So I'm gonna go into the summary and guide for providers, and again, also you as patients that it could be useful for. The reason for the development of the updated guideline document was obviously the ATA intends to publish up-to-date information, and the last one was 9 years old. But more importantly, there's been developments in the science and understanding anaplastic thyroid cancer pathogenesis, evaluation, and the care that it necessitated to come into compliance with really the changed practice at most institutions that are high volume and manage patients with anaplastic thyroid cancer. So, what was the task for meeting and decision making and writing logistics? All of you really should know all recommendations were agreed upon by consensus by all of the members of the task force. We had two methodologists that independently evaluated the quality of evidence. And what does that mean to you as a patient? That is what should be considered the standard of care and high quality evidence. And that was adjudicated, as I said, by the two methodologists. And we only considered published or peer-reviewed data that we cited in the guideline and assessed the quality of the evidence. And we paid great attention to making it user-friendly and display items where you could click through the PDF and go to the area that is most useful for you. And clearly you must know I'm not going to be able to go through the entire guideline, and that's why it's, I think, important for me to emphasize that to you at this presentation, that you could go into the area of concern or interest for you. What are the major changes? I'm going to tell you what I'm going to tell you up front. You know, they say, tell them what you're going to tell them at the beginning, in the middle, and then at the end. So early somatic genomic interrogation now really affects the therapeutic decision-making in patients with anaplastic thyroid cancer. This is a type of thyroid cancer where we could truly personalize the therapy and evaluation in these patients, and really is a seminal part of this revised guideline. Obviously, the enhanced display items improve the user friendliness. And then we've added the good practice statements. These are things that should be done in every patient where there might necessarily be no great high quality evidence. An analogy for this is if you're going to jump out of a plane and you have a parachute, you're probably going to make it and be alive, right? If you jump out without a parachute, you're not. So these are sort of practical standard of care statements in the guideline where there may not necessarily be no evidence. Just as a background, a recent review, the SEER database is a National Cancer Institute database that collects on the majority of cancers in the US, approximately 80%. And this is just an analysis of this data set, and specifically patients that were diagnosed with anaplastic thyroid cancer. And you don't really need to be a biostatistician. Here on the y-axis is the cumulative survival time of patients with anaplastic thyroid cancer. And in the x-axis here is the number of months that they're alive after diagnosis. As you could see, those patients that are able to have an operation, you could see up to an 20% survival, but those where operative intervention is not possible, meaning the tumor is not resectable, the survival is essentially nil beyond 1 year after diagnosis. What this tells us is biology is king. And you could see the CT scan here. This is a patient I took care of back in 2000. Where even the most gifted, skilled surgeon is really not going to be able to resect a tumor here. You could see the patient's spine here, and you could see their trachea is deviated way over to the right, and this massive anaplastic thyroid cancer, and you could see the common carotid artery, the blood supply to the brain, encased with this tumor. But now this patient might have options for treatment and might actually get to the point of having resectable disease. So what is the reason for hope? And I'm just going to share with you some studies that highlight this in more recent times, really in the last 5 years, where clearly it's demonstrated that we could have long-term survival in patients with anaplastic thyroid cancer. This is a nice study done by the group at the Mayo Clinic. And what they demonstrate is patients that get multimodal therapy, and this is primarily chemotherapy, not targeted therapy, which now we have, radiation and combined with surgery, have an improved overall survival in more recent times compared to historical cohorts. And similarly, even patients with stage 4B, and I'll describe to you what that is in just a short while, that you have these patients having survival times that are much better than when they receive multimodal therapy than historical cohorts in the past. And a more recent publication in 2020, this is a nice analysis of patients that were treated at MD Anderson. And what they demonstrate is by the era of their diagnosis, evaluation, and treatment, that they've observed nearly 50% of patients in a 2017 to 2019 having an overall survival. And this is largely to the rapid evaluation of these patients and the possibility of giving them targeted therapy based on actionable mutation, or if you will, driver mutation, that is the mutation that governs the growth and the spread of the anaplastic thyroid cancer. So there's reason for hope in patients with anaplastic thyroid cancer. So what are the critical steps in the management of anaplastic thyroid cancer that we outline in the guideline? It's extremely important to expeditiously diagnose the disease and to engage the team or care team to manage your situation and the extent of disease, patient counseling, organizing what the patient's treatment goals are and objectives. And in that comes the evaluation of surgical options and deciding whether surgery is a go, possible, or a no-go. And that non-surgical decision-making is also very important, postoperative or primary, that is before surgery, chemoradiation, or palliative radiotherapy in patients that have local obstructive symptoms, or systemic therapy, or then also deciding based on the patient's preference, evaluation of hospice and end-of-life care. So the guidelines to accomplish these case states, as I said, is you need to engage a multidisciplinary team and determine the extent of disease and patient counseling. And I'll go into this in a little bit more detail with you so that you understand what's involved in the management of these patients, or what the key steps are. So what do I mean by a multidisciplinary team? This really should include expert cytopathologist or pathologist getting a biopsy done within a week of the patient's diagnosis, that patient seeing a surgeon, the team including a nuclear medicine radiation oncologist, often an endocrinologist or an endocrine oncologist will be involved in that initial evaluation. And then what's different than other thyroid cancers is that we need to engage the medical oncologist. Now, as a patient, you need to understand that this cannot be you reaching out and coordinating your care, but rather these specialists are all involved in your care, and the dialogue needs to be amongst all of these specialists, hopefully in a tumor board multidisciplinary setting. And again, this really needs to be done within a week or two of the patient's presentation. Why is that important? Well, anaplastic thyroid cancer could nearly double in the order of 5 to 7 days. So time is of the essence in getting the diagnosis, engaging the team, and sometimes this might require reaching out to experts across the country. And in the guideline, we cite resources if your local provider is not skilled or institution with this diagnosis. So you should avail of yourself of this resource and make sure you've assembled this team, and which means that this could be virtual and not necessarily at the institution or clinic that you're being seen. And with COVID, this is becoming more and more easier with telemedicine. So how do we determine the extent of disease? And now this is very different than other types of thyroid cancer. All patients with a diagnosis of anaplastic thyroid cancer or who have the differential of possibly having anaplastic thyroid cancer, a CT scan of the neck, chest, and abdomen with contrast should be done expeditiously, again, within orders of a week of the patient presenting. Unlike other patients with different types of thyroid cancer, an FDG PET should be done. It would be fortunate, such as an example in this patient, where we find out the disease was localized. But it's really important because the extent of disease, again, dictates what type of therapy or therapeutic options you have. And an MRI of the brain, again, to exclude metastasis to the brain. So all of these things are very different. We would never do this initial staging workup for other types of thyroid cancer. The other important aspect is the biopsy should be tested for a BRAF mutation, and this could be staining the biopsy slide itself or molecular testing, and I'll go into that in greater detail when I go through the algorithm of the guideline. And then even in patients that might not have hoarseness or difficulty swallowing, a laryngoscopy should be done to evaluate the function of your vocal cord, even if surgery is not considered, because one of the most debilitating and serious problems in patients with anaplastic thyroid cancer is them losing their airway. So we want to assess that upfront initially. Again, this should be done within a week or two of the diagnosis. So we've established the diagnosis, engaged a multidisciplinary team, and determined the extent of disease. These are not necessarily done sequentially. These will probably often be done in parallel at the same time, an important point. And then patient counseling is really important. And just because the patient might be referred to palliative or hospice care, I do not want you to think that intervention is not going to be entertained. It's just an important part of the management where patients need to know what their options are, that they put things into order based on the prognosis of this disease. And this should be an iterative process. What do I mean by that? It doesn't mean if you've decided on one treatment algorithm or if it's surgically resectable, that one does not consider other treatments or doesn't consider if the treatment toxicity is too severe, that they change their mind. So this engagement in patient counseling really needs to be iterative on the order of every 2 to 3 weeks after you've initiated treatment or if you've decided not to engage in treatment. So for some definitions, the TNM staging system is how we stage cancer. Okay, so stage 1 is low stage and stage 4 is the highest stage of any cancer type. And the staging system is based on the prognosis of patients, how long we expect them to live based on their staging. And as you could see, even with the most recent American Joint Commission on Cancer staging system, all anaplastic thyroid cancers are stage 4. And that's because the prognosis is poor. So what is different is there's stage 4A, 4B, and 4C within the stage 4 group for anaplastic thyroid cancer. Here on your right-hand side, I have the pie chart. 4A means the tumor is localized within the thyroid, hasn't spread to the lymph node. Again, based on imaging and determining the extent of disease expeditiously. 10% approximately of patients with anaplastic thyroid cancer belong in that group. Stage 4B is, it's gone outside of the thyroid gland, but still is local regional. What do I mean? It's still in the neck. There might be extrathyroidal extension or regional lymph nodes that are positive. Approximately 1 in 4 patients might be in that category. To be exact, 22%. You see here, though, unfortunately, most of the patients present with stage 4C disease. What does that mean? The tumor has spread to distant sites, commonly lung, bone, and about 68 to 70% of patients fall into that category. So then you could see why it's important to determine expeditiously the extent of disease so we could, and you as a patient could decide what treatment options best suit you based on the information you have. So 10% of patients might be candidates for surgical intervention. And I start with that first because that's really the only possible curative treatment. But we know now sometimes patients, even if they have local regional disease, that's stage 4B or stage 4C, might have a remarkable response to targeted therapy where surgery becomes an option. So R0 resection is the goal for anaplastic thyroid cancer. And what does that mean? That the tumor is completely removed and is negative margins when the pathologist looks at it under the microscope. R1 resection is there's microscopic positive margins. It's not as good outcome as R0 resection, but is not as bad as R2 resection, where it's really unresectable and there's tumor, gross tumor that's being left behind. So as a patient, you want to make sure that you could have an R0 or R1 resection because that's the type of operation that is likely to impact how long you live. Important thing is to never have debulking operation. And I have an image here, a patient I rendered a third opinion on their management. And unfortunately for them, the diagnosis was not established expeditiously with an expert team, and they ended up an attempted resection with a tracheostomy that was placed. And managing a tracheostomy is really difficult. And that's why the laryngoscopy I mentioned in your initial evaluation is so important, because you don't really need a tracheostomy if you're not at risk of losing your airway at the time you're evaluated or in the near future. And that's something that we reserve as when patients absolutely need it, because managing that and taking care of that significantly impacts the quality of life for patients. Obviously, if it could be a curative operation, as I already mentioned to you, that's important. And then again, the important criteria is being the extent of disease and defining based on an expert team what is resectable and what structures could be removed without resulting in significant complications or a risk of death from the procedure itself. I'm going to stop at this point before I go into some busy, but I'll take my time, algorithms to really lay out what your treatment's options are and why those treatment options would be reasonable to embark on. So does anybody have any questions at this point? I understand this is supposed to be interactive, and I don't want to sit here and give a lecture for a whole hour. I see my chat. I'm going to go ahead and scroll through it. Just very kind comments and words. I don't see any questions. So if I don't see any questions, I'm going to continue through the management algorithm, and hopefully you all will have questions at the end. Okay, great. So I guess I've done a relatively clear job of explaining things to you thus far. Let's go ahead and go into the meat of that rapid evaluation I was sharing with you. So when should we be considering this? And sometimes the way a patient presents might not be obvious, but in most patients, they will present, or you will have maybe a history of a multinodular goiter, and all of a sudden the neck mass is rapidly growing, as I shared with you. Doubling time of these tumors could be as short as a week. Or a patient might have a history of thyroid cancer, differentiated thyroid cancer. And approximately 1% of patients might have the tumor de-differentiate and develop anaplastic thyroid cancer. So the immediate evaluation of this rapidly expanding neck mass is the FNA biopsy and cytology, and then obviously evaluating the patency of their airway and securing it only if there's compromise or there's significant risk of it being compromised. So then you want to be referred urgently to a tertiary care center. And again, this is not always possible, but your providers could engage with those individuals listed in the guideline. And it's important, this is the juncture when you're getting your initial evaluation and anaplastic thyroid cancer is suspected, that it undergo molecular testing. I have it in a red circle there. And some institutions might not be able to do the genetic testing, but almost every institution should be able to stain for the BRAF V600 mutation. And there are special markers it might be necessary for the cytopathologist to determine whether it's anaplastic thyroid cancer or not. Because as you can see, I've listed the differential diagnosis there. It could be a thyroid lymphoma, it could be a metastasis to the thyroid. Commonly melanoma, lung cancer could spread there, renal cell carcinoma, or it could be a thyroid sarcoma, squamous cell carcinoma, or other rare types of cancer. And staining for BRAF helps us there, not only for the treatment, but thyroglobulin, thyroid transcription factor 1, and PAX8, which is a transcription factor specific to follicular thyroid cancers or tumors that are of follicular cell origin. And as I've already mentioned to you, the imaging needs to be done expeditiously, includes FDG PET and CT scan and MRI in some cases if a metastasis to the brain is suspected. There I have in the red highlight, then we need to establish the goal of care as these evaluations are done in parallel and comprehensively discuss the treatment options and define the initial care plan, because that might change based on not responding to the treatment or responding significantly to the treatment, where even surgical resection could be possible. And what are the three things important to discuss? Discuss the prognosis, establish the goals of care for the patient, and a consensus recommendation from the multidisciplinary team, and discuss the therapeutic options. And what's really important is to also discuss, obviously, the potential positive outcome from them, but also the side effects and the toxicities that might result from those treatments. So the meat of the guideline is really outlined in these algorithms, and I'll take my time going through them to make sure you understand and figure out where one would land in this algorithm. So after evaluating the extent of disease, if a patient is fortunate enough to have stage 4A disease, again, local disease that could be resectable, then we encourage definitive intention therapy because the potential for long-term survival for patients with 4A disease that could have an R0 or R1 resection is significant. And again, we emphasize avoid debulking surgery, avoid laryngectomy, because patients will fail and pass away, and you're only really making their quality of life poor. And post-operatively, after an R0 or R1 resection, patients should get IMRTs, radiation therapy, image modulated therapy, for which the side effects are much lower, And in some instances, a radiosensitizing chemotherapy with a taxane monotherapy or cisplatin could be beneficial to make the radiation treatment more effective. And the goal of this, even if you have an R0 or R1 resection, is that you want better local control. In simple English, what does that mean? Lower your risk of recurrence of the tumor. So patients fortunate enough to have for a disease, again, the best prognosis, should have definitive operation and postoperative chemoradiation therapy to minimize the chance of recurrence. How about if you have local regional disease? That's 4B. If it's resectable, we recommend to go ahead and do a definitive operation, again, with the same postoperative adjuvant chemoradiation therapy. If it's not resectable, this is where the molecular interrogation or testing becomes important. And this should be done again quite expeditiously. If the anaplastic thyroid cancer is BRAF mutant, then FDA-approved combination therapy with dabrafenib and trametinib, targeting the BRAF and MEK. They're both BRAF and MEK inhibitors. And this is afforded, in fact, it was fast-tracked for anaplastic thyroid cancer for FDA approval because of the excellent tumor response, a significant chance of a complete response, a remarkable, result for patients with anaplastic thyroid cancer that's BRAF mutant. Well, how about if the anaplastic thyroid cancer doesn't have a BRAF mutation? Well, there are some mutations, and these also, some of the agents that target RET fusions that occur in anaplastic thyroid cancer or NTRK or ALK, where we've seen remarkable response to targeted therapy. These drugs are listed here for ALK fusions, RET rearrangements, and NTRK, where in tumor agnostic, that is not specific for one type, but all cancers with these alterations have been published where there's been remarkable response, and some in patients with anaplastic thyroid cancer where it resulted in complete response. So that becomes then the second option for patients that do not have a BRAF mutation. What is possible also is if those patients that are exceptional responders to these targeted therapies, or really even traditional chemoradiation therapy, that they might end up having residual disease, then that now becomes resectable. Remember, I shared with you the CT scan of the patient with the anaplastic thyroid cancer and encasing the common carotid. If that patient, for example, has a BRAF mutation and responds exceptionally, where surgery to resect the residual disease might be possible. Obviously, if they don't have any of these mutations that are actionable, then palliative chemotherapy or radiation, and what do I mean palliative? If the patient has local obstructive symptoms, could be considered, or best supportive care or hospice care. The one thing I really want to emphasize, and I would imagine members of ThyCa would be very much involved in this, is that clinical trial involvement is really important. The only way we're going to learn how to best manage patients with thyroid cancer, not just anaplastic thyroid cancer, is to have the participation of patients with that disease, because many of them are rare and treatment options are limited. And I think by having patients involved, we get the best information, and that might not be for that specific patients, but certainly it's a great contribution to other patients in determining what are possible, or I should say effective treatments in the future. Well, how about the patients with stage 4C disease, that's distant disease? And this is why the goals of care discussion and whether a patient wants aggressive disease, treatment is important, because the prognosis is pretty poor, as I shared with you. And this is the majority of patients with anaplastic thyroid cancer, nearly 2/3 of patients, where we offer best supportive care or hospice care. But it is also possible to consider palliative cytotoxic chemotherapy or radiation therapy if, again, they have symptoms, either local obstructive symptoms, or if they have bone metastases that are extremely painful, where external beam radiation therapy could result in improving those symptoms. Again, these tumors, as in stage 4A and 4B, should undergo molecular interrogation because, again, we have very good treatments with combination BRAF and MEK inhibition where patients have had significant response. Again, for those non-BRAF mutations that are actionable, there's targeted therapy, again, that have resulted in some situations with remarkable response, allow patients to live a longer time. And then with checkpoint inhibitors, specifically pembrolizumab, one could stratify based on high PD-L1 expression or a high tumor mutation burden being present. Those patients are likely to respond to checkpoint inhibitors. Depending upon the response to these three sort of circled baskets I have there, one could decide where, if they've had a significant and exceptional response, where the residual tumor could be resected, or best supportive care therapy, or reassessing the potential of palliative cytochemotherapy and radiation. So now I'm going to really highlight just a few because I can't go through, as I said, the entire guideline. There's 31 recommendation and 22 good practice statements in the guideline. And I'm just going to share with you a few of the recommendations to really emphasize the points that I think are important for patients to know, or patients that potentially could have a diagnosis of anaplastic thyroid cancer. The FNA cytology, as with any thyroid tumor, is really important in establishing the diagnosis at the initial evaluation, but it's really also important because some of these tumors could have dead tissue that you don't get enough viable cells to render a diagnosis. That a core needle biopsy, as soon as you get the biopsy in most institutions, at least at our institution, the cytopathologist looks at it and say, hey, I have an adequate specimen to figure out the diagnosis. If they feel like they don't have an adequate specimen, then to do the core needle biopsy if one is clinically suspecting a diagnosis of anaplastic thyroid cancer. And recommendation 2 states that every effort should be made to establish a diagnosis by a biopsy before going to surgical resection, as surgery may be inappropriate. I shared with you that CT scan of a patient that was rushed off to the operating room where it really didn't have a resectable tumor, and the diagnosis of anaplastic thyroid cancer was not established and ended up with a tracheostomy. Again, trying to avoid that precise situation because that patient is really not helped. It also delays, if that patient had a BRAF mutation, targeted therapy until the wound is healed. So really an important recommendation for providers and patients alike to know. Recommendation 5 states, as hopefully I've emphasized several times, that molecular testing should be performed at the time when one is considering anaplastic thyroid cancer in the differential. And this is especially important in light now that there are FDA-approved mutation-specific therapy that result in some really exceptional response to this targeted therapy. Recommendation 6 states initial radiologic tumor staging, again, is important because the extent of disease, as I hope I've made clear going through the algorithm, really determines what the patient's treatment options are. And unlike other types of thyroid cancer, perhaps where the risk of distant metastasis is low, or that patient would need to have a thyroidectomy, and even if radioiodine ablation is going to be used for distant metastasis, that doing these steps would not alter it. Unlike in anaplastic thyroid cancer, on the other hand, a thyroidectomy might not be appropriate if the patient, as I said, has stage 4 or 4B or 4C disease, thus emphasizing this as a recommendation. Recommendation 8 states that the comprehensive disease-specific multidisciplinary input should be attained before defining the goals of care. And again, this could be done virtually, undertaking therapeutic discussions with patients. Those involved in the management decision should include specialists that are highly experienced in treating anaplastic thyroid cancer. And again, we list those centers in the guideline, and many of those providers already really provide consultations to other individuals or at places where there might not be this expert multidisciplinary team. Recommendation 9, patients should be encouraged to draft both an advance directive in which they name a surrogate decision maker and list code status and other end-of-life preferences, as well as post or most documents where you outline what you'd like to happen. Again, this is because of the prognosis, and then, even if you have stage 4A, one does not know the progress of the disease. So it's really important to establish that up front, and who and your family or friend that you'd like to make these decisions if the situation changes and you are not able to make that decision. And then specifically, you might end up having a great response to targeted therapy, for example, in which you'd want to suspend a DNR, that's do not resuscitate, and choice that you might have made initially. Recommendation 14 states that given the poor overall prognosis of anaplastic thyroid cancer, morbid radical procedures, a surgical intervention should not be undertaken. As I said already, often these procedures, unfortunately, might be undertaken in patients, and all it does is delays their options for having targeted therapy if they should have a driver mutation, and are not life extending and really impact the quality of life of patients. Recommendation 15 states that after R0 or R1 resection, those are resectable tumors, we recommend that good performance status patients with no evidence of metastatic disease should have aggressive upfront treatment. That's adjuvant treatment, additional treatment, even if there's no cancer there, with the intensity modulated radiation therapy and concurrent chemotherapy as a radiosensitizer. The goal, again, there being to reduce the risk of local recurrence. Recommendation 16 states we recommend that patients who have undergone R2 resections, that's the debulking positive margin, or have unresectable but non-metastatic disease with good performance status and who wish upfront aggressive approach are offered standard fractionated IMRT with systemic therapy, because some patients might respond to that. And I shared with you data by decades how the outcome for it had improved because of that multimodal treatment. But if they do have a BRAF mutation, specifically the V600E, that combined MEK-BRAF inhibition should be considered in this context. Recommendation 17 states in patients with unresectable disease during the initial evaluation in whom radiotherapy or systemic therapy renders the tumor potentially resectable. These are, you could consider it neoadjuvant therapy, then surgery becomes an option to hopefully render a patient no evidence of disease with the surgical intervention. Recommendation 20 and 21, and 20, among patients with anaplastic thyroid cancer, that's stage 4C, unresectable advanced disease, wishing aggressive therapy. And if the mutational status is not known, that aggressive chemoradiation therapy could buy us enough time until the mutational status is identified or known, and this one consider as a bridge approach until that information is available. And then obviously for BRAF V600 mutation, the most common type of mutation that occurs in anaplastic thyroid cancer in patients with stage 4C disease, and radiation therapies declined, that combined MEK and BRAF inhibition therapy should be instituted, and again, could result in an exceptional response in some patients. So I'll finish up by sharing with you the link for the anaplastic thyroid cancer. And it's a PDF where it's hyperlink in the table of contents. So you can go to the area that's most appropriate or what you're looking up information for. And it's available for free from Marianne Liebert website. You have that up there. Also, there's a brief introduction of the guidelines by myself and Keith Bible. And then lastly, this is something actually I'm most proud of, is a patient guide here. You could see a PDF that goes through the key steps involved that I already went through, probably much clearer and easier than I did sharing this information with you. Goes through the diagnosis and what treatment alternatives that you have. So that's what I have to share with you in regards to the updated anaplastic thyroid cancer guideline from the American Thyroid Association. And it's been a pleasure to be with you. And I'm happy to answer any questions you have at this moment.
Thank you so much, Dr. Kebebew, for being with us today. And I think we have a question here in the chat.
See, yeah. Hi, my name is Micah. I wasn't able to put my question in the question and answer. I'm wondering if a patient has a history of thyroid cancer that is not ATC, how you determine if they develop new ATC tumors.
Yes, thank you. That's a very important question. So I think one of the first, let's look at the aggregate data. A patient with differentiated thyroid cancer and, anaplastic thyroid cancer in general, we believe forms from thyroid cancers of follicular cell origin. So if you have medullary thyroid cancer, don't worry about it. Any other type, then yeah, you're at risk of developing anaplastic thyroid cancer. So then the question becomes, what's the likelihood of it? I think it's important to know that as a patient, because certainly if I heard the presentation I just gave and I have a history of thyroid cancer, I would naturally worry about it. So the risk of it is in general 1%, okay? So it's a very, very low likelihood. Second is you're getting follow-up for your thyroid cancer, your differentiated thyroid cancer. And that also includes the tumor marker, thyroglobulin, which is not very good for anaplastic thyroid cancer, but imaging. So the imaging is really important. Patients should know, it won't be a mystery. If you do have anaplastic thyroid cancer, the ultrasound should demonstrate significant recurrence or growth of the tumor in the neck. If you are getting anatomic imaging with CT scan, that also would show it. So the best answer I could provide you is if there's something new and it's growing fast, you automatically need to consider that as part of the possibility. And a tissue biopsy is really indicated in that situation to make sure. A fair number of patients will have differentiated thyroid cancer. And sometimes even, I went through determining the extent of disease, and the patient might have a primary differentiated thyroid cancer with anaplastic and they have lung metastasis. Well, sometimes that patient might not have stage 4C anaplastic thyroid cancer. Those lung metastases might be differentiated thyroid cancer. So an astute endocrinologist would order a radioiodine scan to see if the lung metastases light up. If they light up, then it's differentiated thyroid cancer. If it's not, then we worry, and this is in the follow-up period, because if the normal thyroid is in place, the radioiodine scan is just going to go to normal thyroid tissue. But if it doesn't light up, then a biopsy is warranted. It might be poorly differentiated thyroid cancer or radioiodine negative differentiated thyroid cancer or anaplastic thyroid cancer. So a comprehensive workup is important. And if something shows up that's new after you've had an exceptional response to the standard treatment for differentiated thyroid cancer, then you definitely want to think of it, get a comprehensive imaging workup staging, And if it seems more aggressive, then definitely you want a tissue biopsy of the area in question to make sure it's not anaplastic thyroid cancer.
Thank you. Can I ask a follow-up question?
Sure.
Do you need to be more concerned about undifferentiated thyroid cancer?
Yes, that's a great point. So we refer to anaplastic thyroid cancer. It's also referred to undifferentiated thyroid cancer. So they are one and the same. What's really important is sometimes I might have gone through it really fast on that slide I had is then you have a differential diagnosis, and that could include a poorly differentiated thyroid cancer or squamous cell carcinoma, lymphoma, and that's where the tumor markers are important. And it's nothing special. They could use the FNA biopsy that was done and stain them for the markers and then determine, is it anaplastic, which is the same as undifferentiated thyroid cancer, or the other less common types of thyroid cancers.
Thank you so much for that. We have a question in the Q&A. It's what is now the recent overall survival timeframe for ATC based on the new treatment modalities available?
Yes, that's a terrific question. It really, I will answer it by saying it depends. And I don't mean to avoid answering the question. What does it depend on? The mutational status. So if the patient has, let's say, the BRAF mutation, which could occur in anywhere from 50 to 75% of anaplastic thyroid cancer, well, based on recent data I shared with you, the publication in JAMA Oncology from the group at MD Anderson, in the more recent cohort, 2017 to 19, where targeted therapy, immunotherapy was available, they saw 50% of their patients surviving a considerable length of time. So for a patient that presents in that category, one could say we could expect an overall survival of nearly 50% over the next 2 to 3 years, depending upon response to the treatment. I always I'm very careful when I share prognosis for patients with thyroid cancer. Because, you know, even for differentiated thyroid cancer, we tell them, well, you should be alive and greater than 90% over the next 10 years with the standard treatment. But if you're in that 10% that are not alive, guess what? That's 100% mortality rate for you. So I would say it depends on the mutational status. Everybody responds to the treatment differently. But in general, in aggregate, all comers that we're seeing people live longer.
If you had a tumor that was tested positive for BRAF V600E, but it was from, say 2007, and then you had another tumor, say from 2018, that then that one hadn't been tested. Should a new tumor be tested as well for gene mutations or?
Yeah, no, that's not actually the left to question, because I think even for anaplastic, if you have complete response and if something comes back, and this applies to differentiated thyroid cancer, I'm a strong proponent that we need to make treatment decision based on information of the current tumor that's come back or spread, because the molecular profile of that tumor could be completely different than the primary tumor that was treated way back when. So I think it's really important to do a biopsy and do the molecular testing on that tumor that the patient currently has, because you want to make a treatment decision based on the current tumor and not assume that the primary tumor is the same. And there have been some studies that suggest more aggressive tumors also acquire additional mutations, thus the reason to do that specifically.
Good to know. I'll bug your staff later. We do have one more question. Let's see. Given the rapid advances in ATC management, how different is it depending on cancer center or country?
Yes, that's a really good question. Much of the data, the optimistic data I shared with you, really, you're right. It's at highly specialized centers that have done these trials and published this work. So that's why I think the guideline is so important, and that I hope patients with this diagnosis will access it and know immediately. It doesn't mean that patients need to be treated at those centers, but that they have engagement, so that they have the latest therapeutic options and recommendation. Hopefully with that, then the outcome will be similar regardless of what you're able to afford and where you're getting your care, because it really should be that way. And, you know, there have been encouraging reports from less resourced countries where they've gotten compassionate use for BRAF and MEK inhibitor. And some of these papers, actually, I made a point as the outgoing editor-in-chief of Thyroid that we published these papers because they demonstrate some patients in South America, for example, getting access to this treatment had exceptional response. So I would hope it doesn't depend on where you get your care, that if we get engagement of people that are focused on this specific disease process, that people will get the best possible care.
Absolutely, absolutely. Well, I think that wraps it up for us. Thank you again, Dr. Kebebew. And
A pleasure to be
Micah.
with you all. And I hope you have a fantastic meeting, and I look forward to seeing and hearing other presentations myself. Okay.
Thank you so much. And thank you also to Alicia for doing all of our tech work behind the scenes. I appreciate that. Thank you, everyone. Have a great rest of the day.
Bye-bye.
Bye.